Nominal data is random, arbitrary assignment to one or more categories. And usually this is what I would call yes-no data. Is the patient male? Yes, no. Is the patient dead? Yes, no. Is the patient married? Yes, no. You could also say, is the patient male or female? 2 categories, but it's a sort of random, arbitrary assignment.
These are QT prolongers. I'm going to look at them in a minute. But this is pharmacy, and everything, almost everything, is dose related. So if you use higher doses of the QT prolonging agents, you end up with a higher risk of torsades. So this is concentration dependent risk. Reduced drug clearance gives you higher levels because the drug isn't being eliminated as quickly as thought. And that would be renal or liver disease, depending on how these drugs are eliminated. This is a very big one, multiple QT prolonging drugs, like I just said, and you might be looking at a case and you say, hey, that patient's on a QT drug. The patient's already at risk because they had a heart attack or they have heart failure, or maybe they have low potassium. We'll look at that in a second. There's no way you can put that patient on a QT prolonging drug. They're already at risk for torsades. Now, drug interactions can cause decreased clearance if you have an enzyme inhibitor that knocks out the ability of the CYP450 enzyme to clear the drug, or an inhibitor of the P-glycoprotein efflux pump. If the drug cannot be pumped out, then the concentration in the body goes up.
The patch is going to be more long-acting. And the gum and the lozenge are a little bit shorter acting. So often these will be combined in using them for a long-acting control on top of a short-acting for cravings. I like to think of this as similar to a insulin regimen in diabetes where you have a basal and a bolus. Same kind of thing. You have a basal, which is the long-term control of symptoms with the patch, and then you add on short bursts for cravings when you need it with the gum or the lozenge. For all nicotine replacement therapy, remember you have to be 18 years or older to buy it, so we certainly don't want to recommend it for younger. Hopefully they're not smoking because you can't buy cigarettes until you're 18. And combination therapy with these agents especially are effective.
How will we diagnose an ACS? It's with an electrocardiogram and an ECG. We spoke about that just a moment ago. Some of you may have seen ECGs being performed on your hospital rotations, but electrodes get placed on the chest and a tracing runs through a machine, and we get something that looks like this at the side where it's labeled NSTEMI and STEMI. The 12-lead EKG is on a full sheet of paper. These are just little parts of it, but that tracing really helps us determine what's going on at different sites in the heart. And if someone is thought to be having an acute coronary syndrome, the guidelines recommend we get an electrocardiogram within 10 minutes of their first medical contact. So ambulances, EMTs, they're outfitted with ECG machines on the ambulance. So within 10 minutes of them seeing the patient, they're supposed to do that ECG, or within 10 minutes of you walking into an emergency room or a physician's office, that's supposed to be done. And we can get an idea of the acuity of the situation and then make decisions on how to treat you. If we're in a setting where we can draw blood and do labs, we might do cardiac enzymes. The cardiac enzymes that are most sensitive and specific for ACS are troponins. Troponin I and troponin T are the ones we're usually going to get. These enzymes are going to be detectable in the blood within 2 to 12 hours of an ACS.